Hi all, welcome to AETCM, the Emergency Medicine channel. So I am so happy to see you again in this another procedural note. So here today we are going to demonstrate regarding the Ryles tube insertion. Okay, so before getting into the procedure, as usual, we'll see some flash note regarding the Ryles tube insertion. So you can tell Ryles tube insertion, or the other name we can call as a orogastric intubation or nasogastric intubation. So whichever way, there are various names are there. So what is the reason for that means? So if you are inserting the tube through the nasal tube, if you are approaching the gastric cavity means that is nasogastric intubation, or if you are inserting through the oral cavity means that is a orogastric intubation. So whichever way you can call Ryles tube insertion. Okay, so how we can define the Ryles tube insertion means, so we are going to access the stomach or small intestine by inserting a flexible tube through the nasal cavity or oral cavity. So this is the way you can define. So this is my way of definition. You can simplify still more easier also. So we are going to access the stomach or intestinal part, small intestinal part, by inserting the small flexible tube via the nasal cavity or oral cavity. So this is called the nasotracheal intubation or orotracheal intubation or Ryles tube insertion definition. Then when we are inserting, for what purpose or what is the indication means, in a one statement I can tell to give and then to get. So what I am mentioning, to give means, so if the person unable to take orally means, there we can administer some feedings, or there we can through the Ryles tube we can administer some medications. So that is the in a simple way I am mentioning to give. What is meant by to get? To get, what I want to mention here means, so if you want to do any gastric lavage, or if you want to do any some like aspiration, or if you want to decompress the small intestine or bowel means, there you can mention as a to get. So to give and then to get. So this is what the indication. What is the contraindication for this procedure? Main contraindication, you have to start from your nose and then oral cavity. So first we'll focus on the nose. In the nasal cavity, if the person have any facial facial fracture or basilar skull fracture, ethmoid sphenoid bone, there we should not absolutely. And then if the person have any oral secretion, visible large amount of hematoma that is present in the oral cavity means, there also adequate visualization or adequate like inspection or something, adequate examination should be done. After that only you have to proceed. And then if the person have any facial fracture, mandibular fracture, there also some relative contraindication, but that is not an absolute contraindication. And then we are getting into the esophagus. There if the person have any esophageal rupture or esophageal varices means is there means, there also we should not. So if the person have esophageal varices means, while insertion that may be a chance of bleeding chances is there. So there is also esophageal rupture, esophageal varices, there we should not do the Ryles tube insertion. So before getting into the procedural part, so as usual we have to do the pre-procedural preparation and then procedural part and then post-procedural considerations. So pre-procedural preparation, what are the things you have to do? So you have to get into the person. Before that you have to sanitize your hand, and then you have to greet the person, you have to introduce yourself by standing the right side of the person. Then you have to verify the person by seeing the identification ID or by asking the name of the person, age of the person. Okay, these are the things you have to do. Second part, you have to ask your aide to arrange all the needed things on your handshake. Third part, before sending them to arrange, you have to take a informed consent. So you have to, as like in a previous part we discussed, so you have to explain what is the purpose of this procedure, and then you have to explain the R, B, and A. So risk you have to explain, and then what are the benefits by this procedure the person will get, what are the alternative technique here we have. So those are the things you have to explain, and then you have to get into the procedure. Okay, what are the equipments or materials we needed means, first you are starting with your personal protective equipment. So you should have your gloves, and then mask. If needed, you can go with your gown also. Second thing, I need this one, your Ryles tube. That is the hero of this procedure. So you have to take the Ryles tube. This various sizes we have from starting from the 6 to 26. So mainly we will, in our clinical setup, in adult cases we will use this one, green one we will use. So how you can remember this? Commonly we will use orange, white, and then green. How you can easily remember that sizes means, so take our national flag. In that white center portion is a 12 French. So white is a 12 French, and then your green is a 14 French, and then your orange is a 16 French. So by remembering your national flag, you can remember that 12 is a white, 14 is your green, 16 is your orange. Mainly we these three things only we will use in that case of adult cases. So if you are getting into the pediatric cases, based on that age and then size of the baby, circumference of the baby, that size will be different. And then so to verify or to feed that area, we have a 50 cc syringe. Ideally some of the people they will go with the 20 cc also, but ideally you have to choose the 50 cc syringe. And then here I have a RT fixer. So the Ryle tube fixer that is made by the Dynaplast, there's also you have to take. And then you have to take the 2% lox or lignocaine jelly for the lubricant, mean the same time local anesthetic action. So if the person intubated means, so intubated, endotracheal intubated means you have to take your laryngoscope and then Magel's forceps, because it will coil in your mouth oral cavity itself. So to prevent that, we will do the gentle laryngoscope, and then we will, with the help of Magel forceps, we will guide the Ryles tube into the esophagus. So these are the common things. Don't forget about your to perform your hand hygiene, you have to keep your hand rub also. So this is nothing but we are going to perform in the mannequin. For that mannequin we are using this lubricant. So this is what the equipment is. So get into the procedural part. So before getting into the procedure, as usual, you have to tone your PPEs, and then you have to perform the hand wash. Then coming into, so make sure all things in your hand side itself. Then coming into the procedure, in a procedure first you have to do the local examination. So we told a lot of contraindication, some oral bleeding and then massive oral bleeding, then any facial fracture, basilar skull fracture, those and all you have to, by inspecting the person, you have to think. And then second thing, before getting into the insertion part, you have to, what position ideally we have to give. So if the person is conscious oriented with you means, you can make the person in a semi-fowlers, or completely if you are giving fowlers means we can't perform. So you can give the semi-fowlers, or it something which is your comfortable position. So or you can make the person in a supine also. So if the person is unconscious, ultimately we are going with a supine position only. That is regarding the position. And then coming into, if the person is conscious oriented means, so make the person, sorry, not alone the conscious oriented, but for both persons you have to slightly flex the neck like this. Okay, why we are flexing means, so remember, get correlate with your airway manipulation. There we will do the head tilt chin lift manner. By that what we are doing, we are maintaining or we are angulating your airway axis in a straight line. So while giving a neck flexion, it will move your trachea little forward, thereby you can easily get access of your esophagus. That is why we are doing the slightly, you have to flex the neck like this. Okay, this is the way you have to position the person. Then getting into the procedure, so I have to take the appropriate size, either 12 or 14 or 16 French Ryles tube. So I will tell the parts first. This is the proximal region. So this cap, and then you can see that in a proximal part you can see the two portions. So this upper portion is for your syringe. So if you have a syringe with you means, here in this upper portion you have to insert. So if you have a feeding bag means, so this port is for the feeding bag port. So here you have to connect the feeding bag. Okay, so this two parts that comprise the proximal region. So here you can see that this is what the body, so this is the distal region. So in body you can see that radio opaque line. So after insertion, if you took X-ray means, you can see this one black line. So that black line is emitted by this green line. Okay, this is called the radio opaque line. Then here you can see that centimeter also, so what French it is, so this is 14 French, here you can see that. And then you can see the markings like 70 centimeter, 80 centimeters, that marking also will be there, that ranges. And then here in a distal portion you can see this blended end, so the distal portion will be like a blend end. And then here in a lateral, that list distal, in distal lateral region you have some holes or you have some cavity like a region, this is called a lateralize. So this is only facilitate your feeding, or if you are doing decompression means this the part will take a role. So this is what, so first we told the proximal and then body, distal. Proximal you have a two portions, one for your feeding bag, one port for your syringe. In body we have a radio opaque line, and then that includes your what French, what the size it is, and then markings, various markings will be there, that is centimeter, in a centimeter measurement. And then in a distal portion, this portion is a blend ended, and then lateral part you have some lateralize, or you can call as a that feeding ports or decompressing ports. So these are the part. Before getting to the procedure, you have to take a measurement. So lot of controversies or lot of measurement we are following, but one part what we can tell means, so commonly what we are using means, so you have to expose adequately, so with the permission of the person. Then first you have to take the distal portion of the catheter from that tip of the nose to your earlobe, okay, from earlobe to your skippy sternum. That is what you are commonly what we are following in the regular setup. But still there are a lot of studies they are telling, so because of that regular thing, sometime it based on that anatomical, it can be too excess or it can be too short. So this is what we are following, but this is not a correct way. So I read one more study that performed in the group of peoples, around 100 peoples. In that study what they are recommending means, so the same way you can start from your tip of the nose to your earlobe, and then from earlobe to the skippy sternum plus 10 centimeter. So that is from that study you can get will get that conclusion. Almost 98-99% they get succeed. So exactly that catheter placed in the epigastric region or the exactly in the fundus region is our ideal location. So that is what I read. Some other again the some blind people what they are mentioning means, so around if you are inserting 50 to 55 centimeter in average adult or average body build cases means, that is also will reach out to your fundus region. And then one more study what they are mentioning means, again the same thing, tip of the nose to the earlobe to the skippy sternum plus 5 centimeter. So again a lot of calculations are there. So better you can choose that tip of the nose to the earlobe to your skippy sternum plus 10 centimeters. So that is what one of the proof study what we have in our clinical side or what we have in our evidence based. So that's why here I got a 60 centimeter by measuring up to the skippy sternum. So I am adding plus 10, that is coming to the 70 centimeter. So before again inserting the thing, so we already positioned the person. So the catheter also, so if you want to only going for the purpose of feeding means, you can choose the 12 French, that is more than enough. So if you want to decompress the stomach or if you want to perform the lavage means, still more 14 or 16 French is the ideal one. There you will get a larger diameter of lateralize. So these are the some common things what you have to remember. So I remove the catheter and then I have to apply the lubricant gel, okay. So ideally here you have to use the lignocaine gel. So you have to place or you have to apply all over the catheter, almost half of the catheter you have to swipe like this. And then before getting into the insertion, if the person is conscious means, just warn them you are going to insert, and then you can select the left or right nostrils. So before that you have to do the all local examination first, you have to take it. So slowly get into that nostrils. Here also one more important thing, if the person have a deviated nasal septum also, you have to make a choice. So if it is a person have a deviated nasal septum, so if the nasal septum deviated to right side, just imagine right side means which nostrils you will choose, that is a 1%. So here by if the septum is deviated to right side means in your outer nostril diameter, in a right side that outer nostril diameter will be in a large, but if you are getting into the distal region means the diameter of the distal portion will be in a less manner. So if you are imagining means you will get, but again, so if it is deviated to right side, so outer region will be in a large diameter, distal region will be in a smaller diameter. So what ideally we have to choose means left nostrils we have to choose based on that deviation. So which side we have to choose the opposite side. Okay. So if the person here, the person doesn't have any nasal deviated septum, so I am going into the right side. So slowly introduce the catheter. So slowly introduce the tube. So if the person is able to conscious oriented, able to swallow means you can give the small amount of water. Thereby, if the person able to swallow, if by this time of swallowing, you can facilitate the easily you can insert the catheter. So slowly insert, slowly insert. Once the catheter tip reached out your nasopharynx, oropharynx means that will confirmed by the gag reflex. So if the person have a gag reflex means you can check. So one you can confirm the catheter reached out your nasopharynx or oropharynx. So slowly insert, slowly insert. So up to your measured side. So we told 70 centimeter is the ideal thing. So you can, so make sure the person head is in a slightly flexed position. Okay. So I am inserting, and then while insertion also you have to check your oral cavity. There won't be there is not any recoiling in the oral cavity. Okay. So this way I have to insert up to the 70 centimeter. So up to 70 centimeter you have to insert, and then you have to stop. Here we have to confirm our things. So if the person is intubated means, if the person is intubated means gently you can do the laryngoscope, and then you can with your help of Magel's forceps you can guide your Ryles tube into the esophagus. That is also one of the technique. So here I am going to verify my catheter. So I have my aid. So take a 50 cc syringe, then so around 10 to 20 ml of air you have to take, and then you have to ask your aid to auscultate over the epigastric region. Okay, so he placed the epigastric region state, and then I have to give a thrust. Okay, so again I have to re-verify that one. So before getting out your syringe, so you have to fold like this. So your catheter should be folded like this, and then again I have to take a 20 ml of air. Again, it should not be in a one time, you have to do at least 2 or 3 times. Okay, so you have to give a thrust. Okay, so this is the way one thought you can confirm the one type of confirmation, or else what you can do means, so you can take out the gastric content, thereby you can check in the pH paper. If you have a pH paper, you can apply into the pH paper, thereby if it is that gastric content is acidic means, thereby also you can verify. But here also that accuracy of the test will be in a questionable manner, because if the person taking any antacids or proton pump inhibitor means that you won't get any acidic in that pH paper. That is the second thing. Third thing, you can go with the definitive confirmation, that is your X-ray you can take. Fourth thing, what we can do means, that is this is what I referred in the up to date. You can take around 30 to 40 ml of water, then you can inject into that Ryles tube. Immediately you have to take back that water. So if you are getting more than 70%, if you are retaining more than 70% of water means, you can verify, you can confirm that is in the gastric content. This is what I referred in the up to date. So this is a reference from the up to date. First one, you can give a thrust. So it should not be in a slow laminar flow, you have to give a thrust. So you can hear some click sound over the epigastric region. That's the first one. Second one, what you can do, you can aspirate the gastric content and then you can check it in the pH paper. Third thing, you can inject up 20 to 30 ml of water and then you have to revert back or you have to retain back immediately. If you are getting more than 70% of water retaining means, then you can verify that thing in only gastric area. So this is the way. Fourth thing, you can confirm, there is a definitive way you can take a X-ray and then thereby also you can confirm. So here up to this area, after confirmation you have to fix the catheter. Okay, so this is the way you have to do the Ryles tube procedure. So finally, post-procedural part. So here we have to remove, remove your personal protective equipment. You have to discard in a correct waste segregation, and then you have to fix the, you have to anchor the catheter in a two region. First one, you have to over the nasal cavity. Another one more thing over the your forehead. Okay, so this is the two area you have to anchor the catheter, and then finally you have to recover the person. You have to document it properly and then you have to thank the patient. So finally, complication part will start from the nasal cavity. So as like we told, if the person have a basilar skull fracture, there we should not. So if you are not doing a proper examination, if you intubated or if you inserted means, that can misplaced into the cranial valve. So in the case of basilar skull fracture. Then moving on to next thing, the epistaxis also can occur, and then moving into next thing, that is a esophageal varices. So in this case also, if you inserted means there is a chance of bleeding. So that is one thing. Third one, esophageal rupture also can occur. Fourth one, that is your tracheal intubation. It is a most common incident. So in the case of unconscious patients, so there also you have to do. So if it is again, if tracheal intubation can happen, and then if you are not verifying, without verification, if you feed it the person means, that can land up into the some other complication like hydrothorax or pneumonia. Those are the things. Then coming into gastric part, here also that gastrointestinal bleeding can occur. Then electrolyte imbalance. So those are the some common complications that can arise in that your Ryles tube insertion. So do your best. Shalom.